Assalamu alaikum. Okay, let's move forward towards the last part of cell wall inhibitors. Let's see carbapenems. That includes penums, imipenems, doripenem, ertapenem, and meropenem. Almost all cell wall inhibitor beta lactamases have same mechanism of action. So have they? They are less susceptible to beta lactamases. Let's see the spectrum. They have wide activity against gram-positive cocci, including penicillin-resistant pneumococci, gram-negative rods, anaerobes. With the exception of ertapenem, they all are active against Pseudomonas aeruginosa and Acinetobacter species. And for pseudomonal infection, carbapenems are co-administered with aminoglycosides. Let's see the pharmacokinetics. Carbapenems are administered parenterally and they are useful for infections caused by organisms that are resistant to other antibiotics. So you can say that carbapenems are the broadest spectrum antibiotics. But still, MRSA strains of Staphylococci are resistant. Carbapenems are currently co-drug of choice for infections that are caused by Enterobacter, Citrobacter, and Serratia. The species of Enterobacter, Citrobacter, and Serratia for the treatment of these infections, for the treatment of infection caused by these species, carbapenems are currently co-drug of choice. One of the carbapenems, that is imipenems, it is metabolized by an enzyme dehydro renal dehydropeptidase. This enzyme converts the imipenem, metabolize the imipenem into a nephrotoxic metabolite. Then we have another drug which is cilastatin. This cilastatin, it is a dihydropeptidase inhibitor. It inhibits this enzyme, so it is inhibiting the for production of nephrotoxic metabolite of imipenem. That's why we use imipenem along with cilastatin. You can, in other words, you can say that cilastatin increases the plasma half-life of imipenem by inhibiting the formation of metabolite which is potentially nephrotoxic. Other carbapenems are not significantly degraded by the kidneys. Let's see the side effects. Imipenem and cilastatin both have this imipenem and cilastatin. They cause gastrointestinal distress, skin rash, and about CNS toxicity. They cause confusion, CNS toxicity like confusion, encephalopathy, and seizures at very high plasma levels. About meropenem has side effects similar to imipenem cilastatin, but except one, seizures, because it is not metabolized by renal dehydropeptidase. That's why meropenems don't cause seizures, while imipenem causes seizures. The next is ertapenem. This ertapenem has long half-life, but as I told you earlier, it is less active against enterococci and pseudomonas. It is Carbapenems cause pain and irritation when they are administered intramuscularly. The intramuscular injection of carbapenems causes pain and irritation. About their allergenicity, Carbapenems have cross allergenicity with penicillins, not complete. Up till now, we have seen beta lactams. Let's see non beta lactam vancomycin, which is a bactericidal glycoprotein. About the mechanism of action of vancomycin, it binds to D-ALA terminal of nascent peptidoglycan pentapeptide side chain. Vancomycin inhibits transglycosylation. So this thing prevents the elongation of peptidoglycan chain. Vancomycin also interferes in cross-linking. About the spectrum of vancomycin is narrow. It is used for serious infections that are caused by drug-resistant gram-positive organisms like MRSA. Vancomycin, along with third generation cephalosporins like ceftriaxone, it is used for infections caused by penicillin resistant pseudomonas. For Clostridium difficile, vancomycin is a backup drug. The drug of choice for Clostridium difficile is metronidazole, which we will study in our upcoming videos. Let's see the resistance of vancomycin. Vancomycin resistant enterococci and vancomycin resistant staphylococci. Both of these are increasing and they are posing a potentially serious clinical problems. The reason is that because such organisms usually exhibit multiple drug resistance. About the pharmacokinetics, vancomycin is not absorbed orally. When vancomycin is administered parenterally, vancomycin penetrates most of the tissues and is eliminated unchanged in the urine. As I told you, vancomycin is not absorbed orally, so we can use the vancomycin for the treatment of colitis. About the elimination, it is eliminated by renal filtration. That's why it is mandatory in patients with renal impairment. It is mandatory to modify the dose in such patients, like the patients which have renal impairments. Then we have the toxicity. Vancomycin causes ototoxicity, nephrotoxicity. It also causes chills, fever, phlebitis. Next we have, if vancomycin is administered rapidly, like rapid intravenous infusion causes diffuse flushing, which is because of histamine release. This thing is also known as red man syndrome. So these are the toxicity of vancomycin. Let me tell you a point. If a person has rash due to penicillin, so in that person use cephalosporin. But if a person has anaphylaxis to penicillin, in that case use non-beta lactam, like we have vancomycin. There are some other glycopeptide derivatives like teicoplanin and telavancin. They also have similar characteristics like vancomycin. Thank you. Allah Hafiz.